people want to know, not just how much something costs, what's covered, what am I paying, but why is there such massive disparity even across town between two locations?
If anyone's listening right now, the couple of things that we're going to hit that you know really well are one, legal things when it comes to data, interoperability, when it comes to claim data, payer stuff. How do we make sure that people in the community get the care they need? You know about interoperability in general, you know about radiotherapy, and you're a very big policy and advocacy guy. So it was hard for me to kind of pin down what I wanted to start with, but I thought of something unique. And that's a word that I think maybe we throw around a lot and everyone just assumes we know what it entails in its entirety. And I think it's a little more complex than sometimes the way that people use it colloquially. So with that said, when we use the term interoperability in oncology, specifically in healthcare, really in general, what are we talking about it and why is it such a big issue?
So I think to your point, when I hear the word interoperability, it carries such a broad connotation. And even in the subsector of oncology, it carries a broad connotation. So is it interoperability among staff? Is it technology? And if it's technology, that opens up a whole different bucket. So is it interoperability from a system between two systems? Is it interoperability between an EMR and the physician? Is it a third-party software? And what does that look like? So I almost think of interoperability as the pipe framework of connecting various things. And then what are the consequences of connecting some of those things? What happens both upstream? What happens downstream? So I think you bring up a good point is what does it actually mean, interoperability? And it's when two things, in my mind, I kind of simplify it, but can coexist to create something that is either better, easier, bringing more information faster, and accurate. And that's really interoperability between systems in the context of oncology.
100%. And, as a clinician, I first always thought of it as the interoperability of just EMR to EMR. Like, can I access the same stuff that my primary doctor is documenting versus the GI versus whoever I'm, working with? But then I've learned over the last couple of years that it's also data interoperability and data elements. So it's not just the EMR that's an issue, but the data itself that lives, yes, inside of it, but also outside of it. And the way I kind of think about it is, maybe loosely is may not be a good example, but it's really just like using currency in a different country. It's like if you have US dollars in your wallet, you are not broke if you go to another country, but you're not able to necessarily make utility of or purchase the things that are desirable, not because you don't have it, but because you don't have it in the right capacities. And then maybe a step further, which I know my cousins that live in Europe would cringe a little bit, but then you have something like the euro, where the euro can be used in places that do or don't potentially have other currencies. So with all of that said, it's easy to think about how there are a lot of inequities and possibly spillage when it comes to the kind of economic toxicity we have in healthcare that really come down to an interoperability problem. And can you tell me, let's make people appreciate how much loss and bleeding there really is because of an interoperability or operability issue?
Oh, it's spillage all the way to disparity, right? At both ends of the spectrum. And it's because, and that's why, the government, CMS, they're all pushing for some form of standardization. And that's what happens when we don't have a standard pathway, a connection. That's exactly what happens. So much gets lost or unaccounted for in translation. And whether it's payment data, whether it's cost data, whether it's, and I think about this in pharmacy context, with formularies always changing and things changing. What if you missed that interoperability and the information changed over here, but it's facing you as the provider? You don't have that. And so you have no way to update. You have no way to know it's current.
Like a mismatch on the cost of something to the patient, or even necessarily
Absolutely.
the dose thing or the formulation you're supposed to use.
Absolutely. Absolutely. And it's massive because there's so many pieces. It's clinical workflow. It's, front end work. It's actual clinician, what the clinician does. And all of those, the level of mismatch potential for the data not being there is huge, and it costs millions and billions. Now, there's a lot of companies that would rather there not be standardization, right? So like Judith Faulkner's pumped. She's like, Epic and standardize it and let's go. Use our system. We're already in. But that's also that third party network is what's created so many different companies as they may do it 10 different ways, and to try to arrive at the same point. Uh, and what's an acceptable amount of loss in that data once you get to that point?
So you're telling me even the cost when it comes to a major, payer like Blue Cross or United, they're actually having to go and try to access information to not stick the patient with a bill that they believe was unjustified due to not having uh, interoperability between just simply what is being done and what they're seeing.
Oh, absolutely. Absolutely. I mean, that's what spilled out this whole 5 years ago when CMS required, like, the price transparency. That's why this is so big now, is people want to know, not just how much something costs, what's covered, what am I paying, but why is there such massive disparity even across town between two locations?
Oh.
So if I get an MRI, it's the same MRI, it's the same doctor reading. Why is the price so different? And I think that's really been a push, and it's 100% data, to make sure that it's interoperable with these systems. I think a definitive data basically they collate all this data, payer data, what's been paid, what's been charged, and all that goes back to our procedures, our drugs. Why are they so different? Where is there a level set? I shouldn't see for some of the exact same things, even based on location, we should see slight differences, but to see a huge difference, in a swing or a gap is how do you account for that? And so those are the questions that are trying to be answered with the data right now. And the data is revealing things I think that we probably all knew. Maybe the payer rate is better in a certain area, that kind of stuff. So we're seeing some of that kind of spill over now.
And how did we get here? Is this just a product of a capitalistic kind of setup? Not that that necessarily is bad, but is it just that things got propped up as they got propped up and there wasn't a monopoly or
Well,
wasn't an established source and therefore like is that just where we are and can we unwind that?
I think you can, right? But the thing is, it made sense when things weren't visible, right? Or we couldn't
Uh,
see it. And so then it made sense. Like you said, things kept getting propped up, and nobody, unless you knew the data, you didn't really know what questions to ask. You just had a lot of assumptions. And now we know some of the data, some of the disparities, and people ask those questions. And that's what's going to cause the unwind, like you said. And yes, absolutely. I think some of it does have to unwind, especially what we see on the drug and the pharma side. I think we were in Vegas this last week, and we had our keynote was a mom and dad that had their son. Son was an asthmatic, got his first like big job, 22 years old, was on Advair inhaler, and it was $55 a month. It had dropped off formulary for the pharmacy. Nobody let the pharmacy know, but the son had gone to pick his inhaler up, and it was $650 from 60, and he couldn't afford the inhaler, obviously, right? And so he had an asthma attack 3 or 4 days later, was in a coma, ended up passing away. How did that data bypass that, that wasn't communicated to him or the parents, that this is the change, or why is it not covered anymore? And so again, that was all a data driven situation, but now we can see that stuff, and kind of the ugly side rears its head of, we want some accountability and some answers for this.